That's it. So we started the recording. Thank you so much for being here today. This is going to be a little webinar on the canine leishmaniosis diagnosis, treatment, and also the prevention of it. Before I give the floor to our speakers, let me just quickly introduce them in case you haven't seen them before. So we've got here Valentina, foglia, manzillo. Apologies for my pronunciation. I'll try my best. So she's the professor at the Department of Veterinary Medicine at the University of Naples Federico. We've also got Gaetano Oliva. He's a professor at the Department of Veterinary Medicine, University of Naples Federico as well. And last but not least, we've got Gioia Bongiorno, and she is the researcher at the Istituto Superiore di Sanità. Right, perfect. Before we do that, I'll give the floor to Valentina. She will be our first speaker. I'll be in the background for any other technical issues or anything else that pops up. And I'll come back at the very end of the session for the little questions and answer session in case we have throughout the presentations. So without further ado, Valentina, take over.
Okay, many thanks, Carolina. I say hello to everybody. And I try to share my presentation. Okay. Do you see?
Yes, perfect. We can see.
Okay. So I start this talk of today speaking about canine leishmaniosis. First of all, we have to say that when we talk about leishmaniasis, we talk about a group of vector-borne disease caused by an obligate parasite from the genus Leishmania, endemic in more than 98 countries in all around the world. We know that more than 21 are pathogenic for humans, and whose reservoir is represented by canids, first of all, but rodents, marsupial, bats, and other animals. Sorry. Okay, this is a picture of the classification of all the species of Leishmania that we know nowadays. We can say that maybe the main protagonist of infection and disease, both in humans and animals, is Leishmania infantum. In humans, we know three clinical forms: visceral, mucocutaneous, and cutaneous. And in human represent a very severe problem. It is estimated that 350 million people are at risk worldwide, with a high annual incidence and about 12 million cases. We talk today about dogs because dogs represent as a central role in Leishmania, and today we want to understand more about canine leishmaniosis and this disease evolution, to learn more about the diagnostic test for canine leishmaniosis, to illustrate the currently available therapeutic protocols, and to review the prevention strategy that we have for canine leishmaniosis. A dog has a central role because an infected dog is the main domestic reservoir for the parasite. Canine leishmaniosis is due, in fact, to Leishmania infantum and represent a global zoonosis, potentially fatal to humans and dogs too. Is considered as a disease of both veterinary and public health importance because, as I said, infected and sick dogs are considered the main domestic reservoir for the parasite. Leishmania infantum is the agent, is a protozoan parasite transmitted through the bite of scent fly of the genera Phlebotomus in the Old World and the Lutzomia in the New World. When the dog receives an infected bite, it becomes infected and starts to develop an immune response against the parasite. After the infection, the dog could have different behaviors. may eliminate the parasite and come back to a negative status, may persist for a very long time, sometimes also for all the life as a healthy infected with a subclinical infection, or may progress to disease through a preclinical stage characterized by a progressive infection with an apparent healthy condition, or may exhibit clinical signs suggestive of the leishmaniosis. So the sick dogs in endemic area particularly could represent only the minor part of all the infected dogs present in an endemic area. But for us, for a point of view of a vet and for a point of view of a human being, it's important to know all the infected dogs, not only sick dogs, because infected dogs represent a reservoir of the parasite and has a zoonotic potential role in the transmission of the disease. It's important to remember that canine leishmaniosis is a systemic disease that may potentially involve any organ of the body of the dog, but clinical signs are non-specific signs. So we don't have clinical signs or clinical pathological alteration that we can say that are pathognomonic for Leishmania, for leishmaniosis. In this table, we can see all the clinical signs that you can see in a potentially sick dog. So we have general, cutaneous, ocular, or other more rare but potentially present. And all the clinical alteration, clinical pathological alteration of laboratory data. So about the CBC count, the serum proteins, and the biochemical profile, and the urinalysis. So it's important to know that we have to remember all the clinical pathological signs and all the symptoms that we can encounter in a potentially sick dog. The more frequent clinical signs that we can see in a leishmaniotic dog are, for example, lymph node enlargement, weight loss, onychogryphosis, cutaneous lesions, and so on. And it's important to remember that in endemic area in particular, all these signs could be exacerbated by concomitant co-infection with other vector-borne diseases. For example, in primis Ehrlichia canis, that could give a more severe manifestation of the disease. Now we can see some picture of dogs with a very severe condition with systemic involvement, so very severe weight loss or pale of the mucosa, or clinical cutaneous signs, mucocutaneous signs, onychogryphosis, ulcers, lymph node enlargement, ocular lesions. And the previous dogs are very suggestive to be infected and diseased, but we have a condition like that with apparently healthy dog, but infected dogs. And for that reason, it's very important always to perform all the laboratory data that we can obtain, like serum proteins, CBC, complete CBC, biochemical, a complete biochemical profile, and urinalysis too, because infected dogs could not manifest clinical signs that we can see during a visit, during a clinical examination, but could have alteration of the laboratory data. In this study, for example, we have seen that the earliest and most frequent clinical pathological signs in dogs living in a natural condition and naturally infected by Leishmanian phantom were thrombocytopenia and anemia that appears very earlier before all other clinical signs. So it's very important, in particular in endemic area, to do always all the clinical pathological laboratory data that can show a very early infection. So the diagnosis is an integrated approach that has to start with an accurate clinical examination, performing of all the laboratory data, urinalysis, and then the specific diagnosis for the search of the infection, like first of all serology to know the antibody level, antibody titer against the parasite, and PCR, cytology, and histology to highlight the presence of detection of the parasite. So the diagnostic approach of canine leishmaniosis starts with the serology. So we can perform a quantitative serology that could be positive with a high level of antibody, so we have a confirmation of the infection, but could be low, and in this case we can have help from cytology, a histology evaluation, or PCR that can confirm or not the infection. Quantitative serology could be negative, but if we have a very high suspicion of CAN, we can help with the cytology, histology, and PCR to have a definitive confirmation of the infection or not. So the clinical examination plus hematology, biochemistry, urinary profile, and the serology, PCR, cytology, and histology are important not only to have a definitive diagnosis of leishmaniosis, but to stage the dog. And this is another important step. Stage the clinical stage of dogs. We have from LeishVet guidelines a very good help to distinguish a classification in 4 stages of the disease. So we can have a mild stage, a moderate stage of disease, a severe disease, or a very severe disease, according to clinical manifestation, laboratory alteration, and this is very important because it's a point to have not only the possibility to choose the more adequate protocol, therapeutic protocol, but to have a more specific prognosis. And with this, I give the floor to my colleague, Professor Gaetano Oliva, that will treat about the therapeutic protocol during in canine leishmaniosis.
Yeah, thank you, Valentina. Good afternoon again. And I will give a very short overview about the treatment of canine leishmaniosis. You can see here the list of the most frequent treatment that we have is available, and as first line treatment we can consider the combination between meglumine antimonide and allopurinol. This is considered as the first line approach to canine leishmaniosis, with a term of treatment of about 4 weeks that could be extended till 6 weeks, with the dosage of meglumine antimonide of 100 milligram per kilo that can be divided in 2 daily administration. The combination with the allopurinol is intended to have the possibility to attack different targets of the parasite to avoid or to limit the induction of resistance to drugs. Allopurinol usually is used for months in a dose of 10 milligrams per kilo twice daily. And please remember that allopurinol can give the formation of some urolytes of xanthina, and for this reason is strictly indicated the monitoring of urine to avoid or to anticipate the possible formation of these urolytes. Also, meglumine antimonide can give severe side effect. We know from its pharmacokinetic that the antimonide is eliminated by renal, by the kidney. So it's important to check for the renal function during the treatment to avoid or to anticipate the increasing of creatinine. And there is one of the last publication in literature that indicates that the administration of meglumine antimonide can give also pancreatitis. So better to check cautiously the patient in case of some symptoms of gastrointestinal organs that can give the impression of pancreatitis. So we can check during the first month of treatment with this protocol, cautiously the patient to anticipate the possible induction of side effect. As a second line, there is the combination between miltefosine and allopurinol. Miltefosine has a dosage of 2 milligrams per kilogram, and the duration of treatment is about 28 days, so the same, 4 weeks. And due to its particular slow pharmacokinetics, is not useful to have a longer treatment after 28 days. So 28 days should be considered the maximum of the treatment for miltefosine. Miltefosine could give also side effects, mainly gastrointestinal side effects that usually are limited to a few days of vomit and diarrhea. Then you can see also that in some stage, mainly in the first stage, we can use some immune potentiating drugs like domperidone or dietary nucleotides that have the role to stimulate the Th1 immune response, because we know that the protective immune response during canine leishmaniosis is the cellular immune response. So we can potentiate this kind of response by giving this kind of drugs. Next, please. And here you can see the example of clinical stage with the very located lesion on the nose of this dog with no other symptoms, no clinical pathological alteration. In this case, for example, we can use only immune potentiated drugs without systemic treatment, or the combination between allopurinol and immune potentiating drugs. But in this case, for example, of the stage 4, we have to use all possible treatment, but we know also that prognosis of dogs starting from the Leishman clinical stage 2.B till the stage 4 is poor or very negative because of the renal disease. So the fate of the dogs under treatment is conditioned by the possible renal failure. Next. And here you can see all the treatment that we have in literature as first and secondary line treatment. You can see here, for example, Ambisome. The Ambisome is the amphotericin B on the liposomal form, but this drug is not suggested for veterinary purposes because to avoid the induction of a possible strain of Leishmania resistant to amphotericin B, because it is the first line treatment for humans. So the WHO strongly recommend to avoid the use of drugs that are as first line treatment for the human beings. And here just some superstitious treatment that in some regions, like Naples, for example, some owners are using together with conventional drugs. Next. And what about relapse? We know also that some dogs may relapse after treatment, and they are not very frequent, mainly if we start treatment at the beginning of the disease. So when the dog has not a very severe organic compromission. So usually relapse occur for many reasons, but mainly when we start treatment from in dogs with stage 3 and 4. Next. Here you can see some example in literature in which we have a very long follow-up here for antimonial and allopurinol. The authors studied 23 dogs with a very long follow-up till 9 years, and you can see that usually there is always a marked improvement in the dog's clinical situation in the first 3 months. It is important to remark that many dogs may persist in a seropositive state during the treatment and also for months after treatment. So serology is not a good marker to follow the dogs during, or is not the only one marker that we have to use to follow dogs during the treatment. 3 dogs out of 23 experienced a clinical disease relapse, and 3 dogs had 𝐾𝐚 𝐬𝐬𝐢𝐬𝐢𝐬 during the treatment with allopurinol. Next. Here, another publication that my group did a few years ago, in which we evaluated in a retrospective way the miltefosine allopurinol treatment in 175 dogs with a follow-up of 5 years. And you can see that we had 30 out of 173 dogs, 30 relapse. So what is clear, that relapses are more frequent with the treatment of miltefosine and allopurinol when compared with antimonial and allopurinol. So when possible, we have to start always with the antimonials and allopurinol. Next. We know also that we can alternate the treatments because to avoid or to limit possible induction of drug resistance. Drug resistance is widely described in humans, mainly in India and in Africa, resistance to antimonials and to amphotericin B, but also to miltefosine. Remember that in some countries, miltefosine is also used for the cutaneous leishmaniosis by Leishmania tropica or Leishmania major, for example. And we have also experience from dogs of resistance for meglumine antimoniate, for amphotericin B, but also for allopurinol. Recently in Israel, authors isolated strain resistant to allopurinol. And we have also a single dog described in Brazil that developed a resistance both to miltefosine and amphotericin B. So could be also the isolation of strains with multiple resistance that could be inducted by the drug therapy. Next. So when we have a clinical relapse, we have to try to understand the causes for relapse, because not always we have resistance, but we can have many causes that may conditionate the relapses. For example, concurrent immune suppressing condition, for example, immune suppressive treatments for other disease. Next. And please, we have to verify that we are treating according to recommended regimen to avoid under dosages, or we have to treat any underlying condition, mainly co-infection, as Valentina said before, or other concomitant diseases, neoplasia, for example. We can increase the allopurinol dose, or obviously we can switch to alternative drugs, and we can potentiate the immune modulating action of the drugs as I indicated before. We have very few experience of vaccines as immune stimulated treatment. We know that as empirical treatment in Brazil, we have the use of vaccines as immune treatment. Actually, we have no vaccine in Brazil because it was withdrawn from the market some years ago, but till that moment, vets from Brazil used the vaccines also as therapy, but we have no scientific evidence on the benefit of the treatment with vaccines. Next. And how we can monitor the dog during treatment? Obviously, we have to first do a complete clinical examination. We have to repeat quantitative serology and the real-time PCR to check for parasitic load. When? During the first month of treatment, clinical examination, and every 3-4 months with the other parameters like serology and quantitative PCR in the first year, and then every 6 months to check the dog during the time. Next. We can also have the monitoring of what we call healthy infected dogs, because for these dogs, there are no clear scientific evidence on the needs of treatment. So in case of low serology, healthy infected dogs with low serology, we have just to monitor every 3-6 months. And the same with seronegative dogs, but they can have a PCR positive dogs. But when the dog has high level serology, we have to consider to start treatment also if he is healthy infected, because we know that when there is the increasing of antibody levels during the time, this dog is going to disease. So better to anticipate the treatment. Next. Here, for example, you can see some example of very localized leishmaniosis, in which you have here the recognizing of Leishmania parasite in this skin lesion, but with no spread in the organism, because lymph node, bone marrow, clinical pathological evaluation of biochemical and dermatological parameters are all negative. In this case, we can give only immune potentiating drugs to avoid to start systemic treatment, to avoid the possible induction of the drug resistance. Some authors also suggest the possibility to have localized injection of antimonials as intralesional treatment, but there are no scientific paper on this kind of treatment, but it works. So in case you have very localized lesion, you can give localized injection of antimonials. Next. And please remember always that sick and healthy infected dogs must be considered as an active reservoir. So we have to monitor, and when necessary, we have to treat sick and infected dogs. And obviously, we have to protect them to avoid the spread of parasite through the bites of sandflies. But this is a topic of Gioia Bongiorno, and I am giving the floor to Gioia for her part of this scientific seminar. Thank you so much.
Thank you very much, Gaetano and Valentina. Good afternoon to everybody. I will start sharing my screen to proceed with the presentation. I hope everybody is seeing my slide. Let's go with full screen. Okay. So, as Gaetano told you right now, I am deeping now sandflies involvement, or will try to deep in Leishmania life cycle and transmission. So here it is. The sandfly is the only proven vector of Leishmania. This is why it's the only one in which it is possible to complete, in which the parasite can complete its morphotype differentiation. In fact, when a sandfly bites a vertebrate host, it takes parasite morphotype, which is intracellular morphotype. But during the development inside sandfly's gut, the parasite overgoes at morphological differentiation, going through different morphotype till the only able to transmit the infection to vertebrate hosts in the subsequent blood meal, which is metacyclic promastigote. Here it is. And so is the only way in which Leishmania can be transmitted to a vertebrate host, apart alternative methods like transmission, venereal transmission, or blood transfusion or needle transmission, which are not include an insect or other arthropods involvement. Just to give you a little bit of history, the first sandfly representation dates back to 1691, and it was done by an Italian scientist, Filippo Bonanni, in his treatise Micrografia Curiosa. Here it is a wonderful picture and paint, as you can say, draw, sorry. And this is the book, and he was able to draw this fantastic sandfly drawing thanks to the first horizontal microscope that he made by himself 1 year before, in 1690. Sandflies are, just to give you some morphological characteristics, are very tiny insects. They are smaller than 3 millimeter, and their color is characteristic. They are very light yellow, sandy. For this reason, in English, they are called sandflies. So flies are color of the sand. They have large black eyes and slender legs. Characteristic is the position of their wings when they are feeding or resting. So they have this characteristic V shape as shown in the picture. They are not good flyer. In fact, they can actively fly not more than 300, 500 meters, but they can be moved with the wind. So they can, usually they are restricted to vicinity of their larval breeding site, but if wind can transport them also a little bit far away. By the way, this gives this characteristic foci distribution in all territories where they are endemic. Now let's have a glance of their developing cycle. As ectothermic insects, the climate and environmental characteristics have a big influence in their development. Particularly the minimal winter temperatures affecting larval survival stages, and cold and rainy summers that reduce the biting activity season. So here we can see they undergo a complete metamorphosis, starting with eggs and going through 4 larval instars. The species survived in our latitude diapausing in 4 instar larvae, and then there is the pupae and the adult. So in warm and humid environment, instead, the diapause occurs at egg stage. Climate and microclimate characteristics influences the distribution of the vector and also of the disease they transmit, of course. Let's have some idea of the differences and the similarities with the mosquitoes, which are with which we are more used to have contact, so to see and we know a little bit better how they appear. So they are significantly smaller, as we said, 1/3 considering a mosquito, and silent and short-range flights. So they are very no noisy during their flight, as mosquitoes are. And similarities, they both, the female in both species needs to take a blood meal to lay their eggs. An important difference that has epidemiological consequences are the environment in which larval development occurs. For mosquitoes, they have aquatic larvae, while sandflies, here they are larvae, sorry, while sandflies have terrestrial larvae. So they grow in the organic matter, rich of humidity and not exposed directly to the light. And they can grow in different environments, domestic, peri-domestic, like stable or animal shelters, and wild, like burrows, animal burrows, depending on, what's going on, depending on the countries and environment. In Italy, we have, among the 25 species confirmed as vector in Mediterranean countries, we have 8 endemic species. I reported them in the table below. As you can see, Phlebotomus perniciosus is the most efficient vector in our territory, confirmed, and like also 𝐭𝐴 is a good Leishmania phantom vector, able, both of them, to transmit also flaviviruses like Toscana virus or Sicilian and Naples sandfly viruses or fermoviruses. And Phlebotomus neglectus, that is a confirmed vector in Greece and Albania, Ariasi, which is confirmed in Spain and France, Papatasi, which is a confirmed vector of Leishmania major, so in a different species of Leishmania in Eurasia and Africa, Phlebotomus sergenti, which transmits Leishmania tropica in Middle East and Central Asia, and Phlebotomus maschiti, which is found all over European countries, and but only suspected to be vector of Leishmanias in phantom, but not yet proved. And then we have Sergentomia minuta, which is a different genus, but so Sergentomia, not Phlebotomus, and transmit Leishmania tarentuli to geckos and lizards, not to human. Not pathogen for humans, sorry. The sandflies distribution is comprehensive of all warm countries all over the world, and it takes more than 800 species, only 90 of them implicated in Leishmania transmission. They are distributed in the warm zone of Asia, Africa, and Australia, Southern Europe, and Americas, and the different genus, as you can see in the maps below. The most active genus in transmission of pathogen are Phlebotomus and Loutsomia. Phlebotomus in the Old World and Loutsomia in the New World. Approximately 40 Phlebotomini species belonging all to Phlebotomus genus are proven or suspected vector in the Old World, and only 25 in Mediterranean countries, being Phlebotomus perniciosus the most efficient one, as already presented in the European countries, such as Portugal, Spain, France, and Italy. As we know, climatic and environmental conditions are changing a lot, and this is reflecting on the sandfly distribution and spreading in ecological niches in which they were not previously present due to temperature and increase and making a more suitable condition for their development. Here are reported the ACDC maps for Phlebotomos perniciosus and Feliavi sandflies. So as you can see, they are quite distributed all over European countries. Another important characteristic is the influences that latitude has on the beginning of the seasonal activity period of sandflies, influencing their starting, as we can see from the graph, at lower latitudes, we have an early onset, like in Greece on Cyprus, while we have an onset of sandflies activity season in April, while in France, Italy, and Georgia, we have a late onset delayed in June. And always latitudes can affect also the seasonal distribution, sandfly seasonal distribution. For example, in France, we can see at higher latitude we have a monomodal peak distribution, while for example, in Italy and Spain, we have a bimodal peak distribution, till showing a three-modal peak distribution in countries where we have lower latitude. So the presence of sandflies all over the world give us an important epidemiological, from an epidemiological point of view, an important message. We have to protect the reservoir host from sandflies biting. So blocking the disease transmission, protecting also the whole community. How we can do it? We can use topic tools like collar or spot-on solution, or systemic tools. I would like to present some the result of some studies giving us some advice concerning these different tools. For example, using a long-lasting collar impregnated with deltamethrin, we can see that from this study it shows an anti-feeding and fast-killing effects on sandflies population. Reared sandflies, of course, were from colony, were used to test the efficacy of this tool. As we can see from the graph, the blood-fed specimen in the control group and in the test group have significant differences. Mostly the capacity to survive after the contact with this compound. As we can see here, anti-feeding are reported in the graph, the anti-feeding and fast-killing activity. And fast-killing was tested in the first 24 4-hour after product exposure. And we can see that the anti-feeding efficacy was higher than 90% during all the year of test, apart from this little decrease at day 337, and that the efficacy was still high, more than 95% after 1 year. So this could be considered a good tool also for fast-killing efficacy values to be used to protect our dogs. We can also treat our dogs with spot-on solution that was tested to see the anti-feeding and efficacy, showing here that the spot-on protect more than 98% of dog from Leishmania transmission. So we expect to have different benefits from this solution, avoiding the spread of pathogen from already infected reservoir host, preventing the bites for potentially infectious stem flies, avoiding so the spread of Leishmaniasis, and avoiding healthy dogs infection. At last, we can see also the useful of using a systemic insecticide like isoxaxolines, that are another class of systemic insecticides, having a great activity against arthropods. As you can see from the graph, in fact, the test give good results till day 56, so it protects for at least 8 weeks after treatments. Being a study done in different condition, we can see that the in the last point there were no the same values of result, but the final assessment should be due discordance, sorry, should be due to different susceptibility of sandfly strains to this topic systematic tool. By the way, this could be used for a shorter period of time. So another important point to be stressed is the early warning system. We are trying to taking place in CLIMOS project based on entomological and pathogen screening activities conducted in 10 countries, all countries of partners involved in the project, like Austria, Croatia, France, Germany, Israel, Italy, Portugal, Slovenia, Spain, and Turkey. From these maps, we can see that will be highlighted the hotspots in which sandflies are more active and found positive to pathogen screening analysis conducted during CLIMOS project studies. So this is all, and take home message: protect your dog and protect yourself. Thank you.
Great. Thank you so much, Gioia. Thank you, Valentina, Gaetano.